Is Ambien the one that a lot of celebrities kept getting in trouble for like tweeting when they were taking it and stuff? Is that one?
That's it.
Oh wow. Okay, so that makes some sense.
Should we read some Ambien tweets?
No. Nope. No. If it got celebrities canceled, it would definitely get us canceled. So. This is Generation Health. We bring you the latest news, cutting-edge research, and time-tested best practices helping you live a longer, healthier life. Sitting across from me, Joey DiMatteo, PharmD, board-certified clinical nutritionist. How you doing, my friend?
Doing great.
And being very quiet this time, because this is the second time we've had to do this, is Dante DiMatteo, PharmD. Do you have anything to say for yourself?
Not much.
That's
not
exactly
much to say,
correct.
Unfortunately.
And microphone number 3 or 4, however you want to count it, Josiah Schweinberg.
There he is.
There I am.
Engineer extraordinaire. How you doing, my friend?
Doing well.
Excellent. Excellent. Are you wearing black too? Look at that. Look at
Black.
that. Joey didn't get the memo. Sorry about that. We'll
Adding color.
Yeah, we'll do that next time, make it a little more known. My name is Tyler Andrews. I'll be the host of this fiasco. First question. If you're about to start a road trip, what song do you play first? First song of your road trip.
Is this a family trip or
yes.
is this?
Yeah. It's going to be a family trip.
Not that it would differ for me anyway.
Right. Obviously.
Always listen to wholesome content.
So what is it?
I don't know.
Oh, okay. All right. That's not helpful.
The Andre 3000 album.
Yes.
The flute music one.
Mm-hmm.
Yeah.
My wife would probably not be happy, but because it would just add energy to the car. But the kids love Levels by Avicii. And it's really high pay. It's really fast paced. And sometimes I just get into that mode of just getting wild with the kids. And then she just rolls her eyes and gets annoyed. But
That's appropriate.
that would be it.
That's
Yeah.
good. That's good. Especially
hype them up as we're about
for the road trip. That's
exactly.
ideal. You want to get the kids really amped.
Yes.
Hey, you got anything?
I usually just put on I'll start with a DJ set,
Of
like
course.
a pre-recorded DJ set on
Sure,
YouTube, and
sure.
then let that dictate where we go next.
Yeah.
How does Nicole vibe with that?
She's usually just on her phone.
She doesn't
And
fight
I'm
it.
like, oh, do you like this? Do you like this song? That one was pretty sick. Did you catch that? She's like, what?
Wow. Classic. You got something, Josiah.
She's like, no, it just sounds like it's been the same song for the last 30 minutes. And I'm like, that's the point. The transitions were seamless.
That's my wife's opinion of
Yeah.
EDM too. Okay. Well, I would do every time
Bubba Sparks.
we go on a road trip. It's Ring of Fire by Johnny Cash.
Oh, wow.
Yep. Every time. It's a great way. Everybody, you might not like the song, but you're going to be singing along to it by the end of the song. And it's
Yeah.
only like 2 minutes long. So
And then you're like, yeah, we're 2 minutes into the trip.
that's it. I've made it out of my neighborhood. And now we can keep going. If you've been around us for any period of time, you've heard us talk about the gut-brain connection and the gut microbiome, specifically the direct link between the good and bad bacteria in your gut and how it affects your mood and mental health. With that in mind, let's talk about violent female convicts in the Czech Republic. The journal Neuropsychobiology just published a study from a team of researchers in the Republic looking at the differences in the microbiome of female inmates deemed impulsive and violent versus those not called that. They wanted to see if perhaps that might account for the differences in neurotransmitters like dopamine and serotonin that play a key role in the regions of your brain responsible for impulse control. Lo and behold, there was. The study found that certain types of bacteria were more common in impulsive women, while others were more common in non-impulsive women. Of particular note was the role of bacteroides genus. That's the name of the particular strain of bacteria, which seemed to be linked to how the brain uses serotonin and dopamine. So what exactly does this mean for the non-inmate crowd? Well, aside from adding to the overwhelming body of evidence that our gut health does, in fact, have a direct impact on our mental health, and while it doesn't prove that gut bacteria causes impulsive behavior, it does begin to shed light on how someone with an impulsive ADHD, for example, could benefit from having a clean diet with an emphasis on things like fermented foods or our probiotic essentials. Metformin has been a first line of defense for over 60 years for patients dealing with type 2 diabetes. It does a great job helping to lower blood sugar levels, and it's relatively cheap and widely prescribed and available. In recent years, researchers have found it to be effective in other conditions too, linking it to reduced inflammation and improved outcomes for COVID-19 patients and even slowing the growth of tumors. All of that renewed interest has brought it into focus that despite its long history and clear efficacy, we don't really know exactly what it's doing to cause these effects. Researchers at Northwestern University Feinberg School of Medicine were finally able to figure it out. Building on past research, the team was able to use genetically manipulated mice to determine that metformin interferes with the mitochondria of specific unhealthy cells. That interference reduces the cell's ability to produce energy, which then reduces the blood glucose levels. Though not confirmed, the researchers believe that this same interference is likely what's happening to the cancer cells, which would account for the slowing of their reproduction. While this information doesn't change how millions of Americans with type 2 diabetes will be treated, it does pave the way for new research into what else this marvelous little medicine could be used by helping explain its mechanism of action. How cool is that? We've got this question in from a listener. She emailed it to us. She emailed us questions at AskJoeDiMatteo. That's questions at AskJoeDiMatteo.com. That's how you can email us. Love to have your questions, like this one. She said, my husband, who is over 70, has been taking Ambien for 10 years and experiences unusual behaviors before bed, sometimes exacerbated by a single glass of wine several hours prior. He has no memory of these incidents. Given his long-term use and age, could you discuss potential alternatives to Ambien and whether specific foods might trigger or worsen these side effects? Thank you, Susan. Well, thank you, Susan. That is a great question. Is Ambien the one that a lot of celebrities kept getting in trouble for, like, tweeting when they were taking it and stuff? Is that one?
That's it.
Oh, wow. Okay, so that makes some sense.
Should we read some Ambien tweets?
No. Nope. No. If it got celebrities canceled, it would definitely get us canceled. So we're not going to do that. So what's going on here? Why is Ambien causing these sorts of strange behaviors?
Yeah, I mean, obviously with a lot of these questions, we would like a little more information. So there's a couple different angles to take, I guess. I guess the way that I read it is he's over 70 now. He's been on it for 10 years. Something changed. I'm going to safely assume that it's not been 9 years of what specifically
strange behavior,
unusual behaviors before bed,
yeah,
and no memory of it. So I would hope that this has not gone on for 7-8 years.
If it has, Susan is a very patient woman.
Yeah, very. And so is he. But so I think that's one thing to look at here is what's changed.
Yeah.
It's been 10 years. So he's now over 70. Okay. One issue with Ambien is that clearance in the elderly has been shown to dramatically decrease. So clearance goes down, peak plasma concentrations. It varies, but can be up to 50% higher. So the dose hasn't changed. Nothing's changed with you, that would have maybe a direct impact. But over time, as you age, you're going to clear less of the same dose of Ambien that you've been taking.
Okay, pretend that I don't know what peak plasma levels and clearance means. What are we talking about here?
Yeah, so you take a medication, any medication, and it's to achieve some type of blood level.
Okay.
And the dose is targeted to achieve a certain concentration that gives you a certain effect. That's why there's varying doses of all the medications. So whatever dose it potentially, just going by the most clear example here, 50%.
Yep.
So whatever dose you take, maybe 10 years ago, it's achieving a certain plasma level. That same dose and that same person is now 50% higher.
Wow.
Later on, like all these things that goes in a spectrum and it occurs over time. You may have had a medication added, a lot of different, but just in the most simple terms, the same dose is giving him now higher levels in the blood.
So realistically, that's not a stretch to say that 10 years later that could be the case.
Yes, and it's the elderly factor. It's not, well, now he's 40 years old, he's been on Ambien for 10 years and this is occurring. Not that couldn't happen, but the age kind of starts to put you into a new bracket of how your body is clearing a medication like that.
60s to 70s is a bigger change realistically than 30s to 40s.
Yes, exactly.
Okay. All right. So clearance level and peak plasma level, that's a strong possibility. So what you're saying, if I understood you right, you're saying it's entirely possible that just because of his age, the medication is hitting harder.
Yes. The studies have shown that even on lower doses, side effects become more severe over time. Assuming that the clearance is decreasing and the concentrations are now higher.
This strikes me as something that would have popped up in school.
Yeah.
Something you do a presentation on, a question on a test.
Yeah.
Maybe what seems like a minute detail could be, worth investigating. Because who knows? He could have blood work done and his liver and kidney function, despite his age, could still be normal. But But I think Joey brings about like the primary, I think, focus, especially if there was a stark change like this. Should
this not be something that his doctor would presumably catch and go, hey, you're still taking that? We should maybe consider dropping the dose. How's that treating you? Like, is that not something that primary care would notice?
I think it's one of those things that, like we talk about a lot here. It's about having those conversations with your doctor. Why would the doctor assume? They're not say, oh, you're 66 now. How's that Ambien treating you?
Yeah.
They're going to wait for some feedback. So whatever's going on with you, like we often say, talk to your doctor about it, be open about it and honest about it.
Okay. That makes sense.
And I think we'll get into more of the minutia of this whole thing, but per recommendations, once you're initiated on something like Ambien, something that, essentially serves as a hypnotic medication, something that requires a little more monitoring, I would say, than some other options, you would think that a therapy like this would be reevaluated every 6 months or so, or every year or so. There's not an explicit recommendation in, the package insert or in the guidelines that, Zolpidem is only used for short-term use. It's only used for this or that. There's not a black and white, from my understanding, on how long therapy should last, but there's always the recommendation, again, kind of per guidelines, that you're always continually reassessing how something like this is occurring, because it has, I think like we'll mention, it has the potential for abuse. It has the potential for dependence. It has, is a little more of a, it's a little more of a common agent when somebody if they were to discontinue use, you'd need to use a little more of a tapering approach. So, again, I think we'll get into more of that, but it does just require a little more focus than the average med for sleep, let's say.
Dependence being a perfect place to go. 10 years on a medication like this, is that not dependence? That seems like that would be kind of the definition of that, wouldn't it?
Yeah. And I don't necessarily say that. I should be cautious with the context of saying that. And I don't often say, I don't think it's worth saying, dependence in the sense that we need to scare them.
Right.
But, just in both senses.
Your body is relying on
this. There are certainly people who, per case reports and per just about anywhere you look, that there's the potential for misuse, I think, is where we'll leave it. But dependence and tolerance, that doesn't always mean that you have tolerance to your blood pressure medication. You have tolerance to an antidepressant. It doesn't, it's not all in a negative light.
Right.
Yeah. And Ambien, in typical use has a very short activity time, and people, again, outside of abuse, aren't taking it during the day. So the medication essentially is on board for a short amount of time relative to other drugs of abuse, whether you're drinking over an extended period of time, you're taking a benzodiazepine 2 or 3 times a day, and plus that in and of itself lasts longer. So anything that's lasting longer, anything that's quote unquote on board for longer does, and then it potentially could be, misused, adds to that possibility. But in general, somebody taking it as prescribed, yes, there's maybe some tolerance dependence that can evolve in terms of, well, when I'm coming off of it, what do I do? Absolutely. But in terms of having the direct effect of dependence that you typically think of, when you're dealing with a drug that can be abused, like a benzo, an opiate, even alcohol, it's lower on the scale.
Okay. All right.
Agreed. So, yeah, it's a good way to put it. And also I would add that a lot of times before being even initiated on something like this, I think just speaks to how thorough the workup is, how thorough the conversation is, whether, when you present to somebody who's having issues with sleep, whether it's staying asleep, falling asleep, excessive sleepiness the next day, whatever it is, as a part of that evaluation, whether or not something like, something that acts on the benzodiazepine kind of pathway that might dictate whether or not you're a good candidate or not, based on your history of use of different substances, all of those sorts of things too.
Yeah.
So, but Joey's absolutely right.
So bringing it back to Susan's question here, is the alcohol doing anything here? Is the food, whatever he's eating at night, is this all playing a role, or is it just the Ambien?
Yeah, we'll start with the alcohol. Just going at face value, literally one single glass of wine several hours before doesn't sound like much, potentially is not much, but again, that's taking it literally at face value. Alcohol still hits GABA receptors. Ambien hits GABA receptors. It's contributing to the effect directly that medication and that alcohol are having on your body. There's an additive effect of that. Okay. So that's first thing. Second of all, alcohol is cleared by the liver. So when you look at these kind of things, we already talked about the decreased clearance. It's rarely black and white. Mm-hmm. So you're on Ambien, maybe you're aging and clearance is going down, liver function's going down a little bit. Normally, whatever the case may be. Maybe you're on a statin drug cleared by the liver. Maybe you're on 2 or 3 other meds, 70 years old. You may be on multiple drugs cleared by the liver. Now you're adding alcohol, then kind of the end of the night, you're adding Ambien. So all of those things can come together. And at 62, maybe just one less medication, maybe liver's functioning a little better, no different scene. You start to add those things up. So the average person, 1 glass of alcohol hours before Ambien probably is going to make a difference. But when you add all those things in, let alone if it is 2, sometimes if it's 45 minutes, the glass is finished. Now those things all start to maybe change that. But I think that's a critical factor here is the alcohol combined with everything else.
Okay. So it from what you're saying, it's entirely likely that single glass of wine several hours prior is either not exactly a single glass, is not exactly several hours prior, and regardless, probably is not clearing his blood in the same way that it would have 10 years ago.
Yes.
Okay. All right. That makes sense. And you said it's they both act on the GABA receptors?
Yes, they both have in varying ways activity at GABA.
So does it mean then, you said it was additive, that they compound the effects on each other?
Yeah, they're both in different ways hitting the same receptors. Like alcohol with Xanax or a benzodiazepine drug. One's more of a pure agonist, the other one's working on the receptor to make it more sensitive. So when you add those things together, it's above and beyond. It's synergistic in the sense of it's beyond what the separate components would be on their own.
Right.
What E equals a higher amount than the other two, higher effect.
Greater than the sum of the parts.
Yes. There you go. Nailed it.
Okay. Interesting. Okay, so this is one of those medications that you really don't want to drink while you are taking this medication.
Yeah, because there are medications where that's said, and then there are other medications where it's more critical. Anytime you're dealing with a drug of abuse or that's going to have a similar activity like we talked about with GABA, anytime those things come into play, the recommendation to stay away from alcohol goes up, and this definitely applies.
Okay, all right. Fascinating. What else we got on this? The food element, is there some reason to think that he's eating something that could be increasing or adding to the the consequences of this medication?
Based on, her explanation of what's occurring, I nothing came to mind about what stimulatory or odd.
Not for me either.
Yeah. Now, in the sense of sleep generally, there are obviously foods that tend to agree or disagree more with somebody, whether they have acid reflux or whatever the case. There are things that you would want to avoid if you're particularly sensitive.
Okay.
But separate from that issue. You could lump in beverages into that. This is more of a sleep hygiene thing.
Yeah.
I mean, you think about the one that if you open up Instagram, you'll see somebody telling you to not drink caffeine, X hours before bed, which is valid, especially
I think
if you are somebody a little more.
22 hours before you go to sleep is the last time you're supposed to drink.
Depending on what video you see.
Yeah.
Yeah. Every sip of caffeine or your energy drink, you're like looking at the
5
clock.
minutes less of sleep.
Yeah. Yeah. You just feel that your sleep quality just
resetting the
eroding.
timer.
Yeah.
Okay, so how do we get here? How does a 60s or 70s year old man end up on Ambien? Ambien is intended to help you fall asleep and stay asleep is the idea, right? So what does that process look like, and why is somebody taking this in the first place?
So there are, I believe, 7, 8 different categories of sleep disorders. So disorders, we'll focus more on insomnia related disorders. In this case, 9 out of 10 times somebody has, a sleep onset insomnia and they are initiated on something like Ambien, or maybe they're using a more sedating antidepressant. But again, there are
onset being falling asleep.
Mm-hmm. Yes. So there are many different categories that, the Academy of Sleep Medicine sort of breaks these issues into. Again, we'll focus more on insomnia specifically, but there are hypersomnias. There are sleep-related breathing disorders, sleep-related movement disorders, parasomnias, things that I think are beyond the scope, but at least worth mentioning.
Sure.
Now, in terms of insomnia, just because of the focus of her question is insomnia. There are, I think I saw somewhere from 50 to 70 million people have in the United States experience some sort of sleep disturbance.
Wow.
Whether that is a clinical, diagnosis for insomnia is a little more tricky, but it's not all of those people.
Right.
But again, it's more centered around this part of the discussion. So most likely, this individual presented with a difficulty in falling asleep. Maybe they were often waking up in the middle of the night. They couldn't stay asleep. They were waking up at, not the most ideal times.
Sure.
Maybe they have racing thoughts around sleep, or stressing around sleep, or kind of this negative loop of thinking around sleep. So any combination of those symptoms were likely, explained or expressed at some point. And, depending on the severity, the frequency of those things, that's when pharmacologic treatment options are discussed. And there are also behavioral options. Cognitive behavioral therapy is another important aspect to all of this.
Mm-hmm.
But also should mention even daytime symptoms. So a lot of times people can't quite make sense of why they, brain fog at work is a little more notable, or they can't really focus. They can't concentrate. They're excessively sleepy. Yeah. So excessive daytime sleepiness is just another, kind of hallmark symptom of somebody who might be experiencing insomnia.
So he goes to the doctor, he gets prescribed Ambien, and is it typical that somebody would stay on it for this long, or is it one of those things that you get on it, kind of get over a hump, and then you're supposed to come off of it in theory?
It's just not as well defined as you'd think.
Okay.
Again, when you present with something like this, the evaluation process is just so multifaceted, because
Is that a flow chart of how you?
Yeah.
Okay, let me see that for a second. People should see this. This is what that looks like. That decision-making tree looks like. That there's all kinds of different directions it can go on whether or not somebody should have a medication.
Yeah, and admittedly, as complex as it looks, it's still a drastic oversimplification of what the process looks like.
Yep.
So, the reason why that's important, again, is because it's certainly possible, but primary insomnia, or, an idiopathic insomnia where you don't necessarily know what the root cause is. It's just something that maybe somebody dealt with as a young child and it persisted all the way up into adulthood. No explanation for it.
Right.
Those I would say are a little more rare.
Mm-hmm.
A lot of times the insomnia is comorbid with another medical issue or psychiatric issue, or there are other medications, or there's a substance use issue, or just whatever. And then as a part of this, gamut of treatment, you are also addressing these other, kind of, again, comorbid issues. So that could be, depression, is a huge one. So that would be something where depending on what you're being treated with, if you're being treated at all for, depressive symptoms, that, there's a medication that could be used to handle both of those issues. Maybe there's an added, more sedating, antidepressant that's used at nighttime at a lower dose, something like trazodone. But in general, that's how it goes. When pharmacologic therapy is initiated, there's also psychological and behavioral treatment that should go along with that.
Okay.
I believe that the evidence is less in favor of just psychological or behavioral treatment. It certainly can have some impact, but usually when somebody is having really severe issues, it's going to take some sort of combined therapy, at least initially.
Okay.
Now, I'm not directly treating people for sleep issues, but just the way that you see these things go, it wouldn't surprise me if over time, maybe some of the cognitive behavioral therapy stuff kind of falls by the wayside before the medication therapy does.
Yeah.
So I think, again, per the guidelines, per any of these recommendations, cognitive behavioral therapy, some sort of psychological intervention just has to run parallel with whatever treatment is going on. And this way you're always checking in with how well a medication is or isn't working. Have you had to go from intermittently using a sleep medication to every night? Is it the opposite? Did you use it every single night for a couple months, and now you're only having to use it every few nights? There's so many ways that this can go.
Right.
Point being, it really does just take a continual, combing through the symptoms and, just their experience.
Okay. So this is something that theoretically Susan's husband should be checking in with a doctor periodically and making sure that this is still the appropriate treatment. One of the things she mentioned or asked about was if there were any alternatives to Ambien. She didn't say, but I mean, whether they're natural or something else. You were talking about CBT. That's a great option. What other alternatives are there?
Yeah, I think one of the things that's going to come up in a conversation like this, maybe specifically or just generally, is Benadryl and Unisom. Those to take once in a while for sleep, if you can't fall asleep once in a while, I think are fine. But it's just something, because whenever people hear it's over the counter, like when we talk about it times, especially like an Advil or something like that, when it's over the counter, it has a certain safety assumption.
Much safer.
Yeah. So just be very careful with Benadryl and Unisom, diphenhydramine and doxylamine. Especially in the elderly, they have significant anticholinergic side effects. They're basically like drying side effects. So urinary retention, constipation, dry mouth. So now again, a lot of these things combined. Elderly people, males will have certainly some issues. Urinary bladder issues, constipation can be a more significant issue. Also, anticholinergics over time have been linked to cognitive impairment.
Wow.
So now we're kind of going over what not to do now.
Right.
And again, I preface this by saying if it's a once in a while thing that you kind of have by the bed and you take it, once a month or something, there's nothing wrong with that. But prolonged use, like, this is over the counter, it's better than Ambien.
Yeah.
That's just something to be wary of. Between the two, Unisom definitely has longer activity, so it can even increase daytime sleepiness, because that can be an issue with Benadryl as well.
Wow.
So again, unless it's a very rare occurrence, it's not recommended to go that route. Along those lines, to wrap this end of things up, it's critical to understand the chemical name of them. Like I mentioned, doxylamine and diphenhydramine, because you'll have people, who just don't know better, that would say, well, no, I don't take Benadryl. I take Advil PM, or I take Tylenol PM, or I take, just make sure that ingredient is not in there if you're concerned about some of those side effects.
Got it. What are there any other pharmacological options? Maybe anything gentler or with fewer potential strange behavior side effects?
Yeah, some of the big ones include trazodone, mirtazapine, doxepin, amitriptyline. Okay, so basically, like Dante had talked about, they are technically antidepressants, and they're kind of referred to as low-dose antidepressants. So you wouldn't be taking these typically in the same dose that you would to get the antidepressant effect. These are basically older versions of antidepressants. They're not SSRIs. So at low dose, they're sedating. All right, so they're commonly used. Are they as effective as Ambien? That is not shown to be the case. But again, we're looking in this particular situation as essentially a failure of Ambien. It works, but the side effects are falling into the severe category.
Yeah.
So unless you can directly link the alcohol or anything like that, you essentially have to say that Ambien at this point is something that needs to be stopped.
Time to move away.
Yes. So this can at least be an option from a medication standpoint that's in between those two. So just watch, similar with the anticholinergic side effects that I mentioned, doxepin and amitriptyline are much more likely to do that. Mirtazapine is much more likely to cause weight gain.
Okay.
So trazodone tends to be one that we see more and more if, kind of stepping down. Because again, we're saying don't do OTCs. Ambien doesn't work. So, I'm trying to get to the point where maybe we make a recommendation. And from a medication standpoint, I think trazodone could be a good option given the issues with the others. And in this particular situation with elderly, et cetera.
Okay. If somebody I guess this works for Susan's husband as well, but if somebody's been on one of these on something like Ambien for a long time and they are wanting to move off of it, you had talked about tapering off. What does that look like for most folks?
It really just depends on the individual. Obviously, something you'd want to do under
supervision.
Absolutely. So, I mean, as it starts as simple as, half the dose every 2 days, every 3 days. And I don't believe, especially in this instance, being on it for over 10 years, that there'd really ever be a night that you would go without it.
Yeah.
I would imagine. But just alternating half doses down to quarter doses eventually, whether some people that might take weeks, some people that might take several months, might take some ups and some downs, that's at least what we would say to somebody in the pharmacy,
right?
Is that just be gracious with yourself and do it under the supervision of your PCP and or psychiatrist, whoever maybe you're going to with, for the CBT aspect of things. But it could take any number of weeks or months, or just depending on the person.
That makes sense. But just be aware and I like that. Be gracious with yourself.
Mm-hmm. I mean, we've even compounded odd, in between strengths for people for different medications like this, not Ambien necessarily, but things that, for some people they're a little sensitive to the changes and sensitive to the process itself. That, who knows, maybe you have a compounding pharmacy that can, make you some in between strengths or whatever the case. There's less evidence for those increments, but I think if the goal is to, between the provider and the patient, that they're trying to go down that path of decreasing the dose, however you do it, as long as it's safe, then, I think that's a good thing.
That makes sense. Anything else?
Yeah, from a supplement standpoint, melatonin is still a good thing to try. Absolutely. Especially maybe once you completed that wean off. We carry a product, Essential Sleep, that's a combination of ingredients that have kind of that synergistic effect. Yep. GABA to work on those GABA receptors. 5-HTP works on serotonin. L-theanine helps to kind of calm the brain. Also has melatonin in it and glycine. So I think from a supplement standpoint, that would be a great option. Either way, been on Ambien for 10 years. Weaning off, yes, but there's probably going to need to be something else on board.
Makes sense.
And whether it's the medication, if you want to step down that way, like a trazodone or one of the others that you and your doctor would discuss, I think that's a fine option. It's not going to have those side effects, the memory loss, the behaviors, things like that are going on with the Ambien, and then of course or the supplement being on board too. I think there's going to be something would need to be taken kind of to replace that over time.
That makes sense, and it sounds like, especially at this point, if it's getting into strange behavior and memory loss, that it's time to consider some alternatives.
Yeah, it doesn't mean just don't take it tomorrow. It means wean off with your doctor, but it like I said before, it's essentially a failure of the medication at this point. The side effects are outweighing the benefits, and there's other options.
Okay, very good. Susan, I hope that helps. I hope your husband is able to get a good night's sleep without all that stuff soon. And I hope he remembers everything that happens from dinner onward, because that's intense. That is it for us this week. If you have a question, like Susan did, email us questions@askjoedimatteo.com. That's also the website where you can find all of this wonderful stuff we talked about. All the products we sell, our show notes are always on there. Past episodes of this show, the show that started all of this, the Ask the Pharmacist show, all available at askjoedimatteo.com. askjoedimatteo.com. If you enjoyed this show, if you learned something, please share the episode with somebody that you know. That is the best way you can help us. The second best way is to go to the website and buy one of these wonderful products. Other than that, I think that's it from us. You guys have a wonderful, wonderful rest of the week or month. However long. Or life. If this is the last time you ever watch this show, thanks for watching.